Good morning and welcome to Workshop 7. Is that good? Okay. National and International Models of Quality Improvement. We have an excellent selection of presentations for you this morning, which will demonstrate methods and examples of quality improvement work throughout the U.S. as well as internationally. We will start with Christy Gott, a pediatric nurse practitioner at the University of Virginia Children's Hospital in Charlottesville, Virginia. Her presentation is entitled Transforming Transition, Take 2. Oh, that's better. Is it my teeth? Yeah, of course.
Good morning. I feel privileged to be here, and I'm looking forward to guiding you through the development of our transition program. I have no disclosures. I'd like to share with you our team's experience building a formal transition program to better meet the needs of our patients. It felt like beginning a very long hike when we were already busy dealing with some tougher transfers. So we really had to get comfortable stopping along the way, and as always, while on the trail, supporting each other to accomplish the tasks at hand. We discovered with the amazing guidance of our QI coach, Rhonda List, that using QI as a roadmap, or in this case, a hiking map, was an extremely helpful way to scope the work and start scaling it to our needs, as well as fully dissect our problems and barriers. We will also discuss some methods we use that may be helpful to you as you move forward with or reevaluate your transition programs, reviewing key tools and resources that have moved us toward success. We are happy with our early results, but also realize that we have some additional changes to make to keep ensuring success. The story always begins with patience, does it not? It only takes watching one have a suboptimal transfer to make you want to make change happen. The motivation to more closely examine our processes started with seeing patients having needs that we weren't meeting as well as we would like to. This, in combination with an amazing DMP student that was looking to do a capstone project at just the right time, helped us to take action and start putting the cornerstones of a program in place. What the existing research shows us matches up exactly with our clinical experience. It takes all of childhood to get ready to do this. And we have to figure out the best ways to partner with our patients so that they feel empowered and successful when they transfer to adult care. First, we assembled an amazing subgroup to tackle the work needed. And the same team members are still steadfast in meeting 2.5 years later. The dedication of this group, as well as the set monthly meetings, are really what has driven us forward, as well as the various tools and trackers we've put in place to monitor our own progress, as well as the satisfaction of our patients. We wanted to better provide consistent connections for people during this difficult time. So we began with an extensive literature and resource review, both inside and outside the CF arena. It wasn't a trouble at all for any of us to figure out our own personal connection to why we wanted to do this work. And that really is what has sustained us. Sorry for this very busy slide, but there's no other way to present an SFMEA. We learned pretty quickly that QI is actually messy. We had introduced the concept of transition widely all the way down to the age of 3 to our patients and families, but then realized that we had to refocus ourselves on the patients that were nearing the transfer window. So we scoped out the most pressing issues, defining problems and mapping processes during this time frame. When defining problems, we noticed that some were in content, some were with tracking, some were in mapping and processes. Defining and dissecting problems was even more complicated when it was a piece of our program with many barriers or stakeholders. This SFMEA tool is an example of one of them, our meet and greet session with the adult team, which we set up during the final quartile of the pediatric year. It was a process that had significant issues. Not only did we need to set up formal meet and greet sessions with 2 busy CF teams and a patient, but we had to solve barriers to getting it done well. This had been a virtual process during the pandemic, and then at times after the pandemic was becoming in person again, and still at present state can be a hybrid process. So we had to dig deep and discover where we were falling down and put more structures in place for this very important event. Use of this tool has been especially helpful to understand all of the different relational junctures present in the multiple processes on the pediatric side and then how it interfaces with the adult team. There were many changes and improvements that we needed to put into place to make this work for both teams as well as the patient. Two examples of interventions we put into place were obtaining a special PVP so that both the adult team and the peds team were up to date on last-minute changes with the patient. And then making sure we hear the patient voice by doing a meet and greet survey on Qualtrics at the end of the visit. Once some of the main problems were dissected and plans for new processes were put into place, we were able to start looking at the larger picture and focus on developing our own theory for improvement. We had a lot of good ideas and process pieces, but we lacked a systematic way for applying and tracking them. So let's take a closer look at the methods that we used to get started and now in a sustained mode. We clearly stated our global aim, as well as several smart aims about the program. And we also had to get comfortable with the fact that QI work is not always linear. Oftentimes we found ourselves working backward, and we had to do so until we could problem solve and then put the cornerstones of the program in place. Our aims led us to specific interventions that would organize, standardize, and track a series of processes that were housed under our new program. None of these processes had any prior measures, and there were no existing tools. Using a key driver diagram, we were able to organize what we learned from the literature and best practices to create the theory for our own work. The key drivers, or the core elements that you see in the middle, were the conditions that we felt needed to exist for us to reach our goals, and interventions were designed and tested through multiple PDSA cycles. These key drivers are noted in the middle. The change ideas or interventions are located on the far right. The gray boxes have been adopted and are in a sustained phase. Several others, such as the EPIC flowsheet, interdisciplinary presentations, and timely ID of the final pediatric year, will be shifting to gray in the near future. Items that remain on our to-do list are in white. Setting monthly meetings as a subgroup to review changes and discuss adopting or adapting actions greatly benefited our movement forward. In addition to the monthly meetings, each of us was working behind the scenes to formalize our tools, track our processes, and hold each other accountable for honoring our intentions on a weekly basis. Let's take a closer look at how we standardize the workflow. At the top, you can see the categories for our monthly spreadsheet monitoring. We anticipate the patient's transfer year, monitor their last 4 co-produced visits with us, their readiness assessments, dates for team presentations, meet and greet sessions, and future visits. Our routine joint meetings with the adult team were performed on a quarterly basis. We have a shared EPIC patient list so that the adult team can see the patients that are queuing for transfer. And we also have a back-end care team member checklist, which you can see in the middle, to guide us during the last 4 co-produced visits. These tools and processes, plus weekly monitoring of our EPIC flowsheet use during our clinic huddle, have all aided us in becoming consistent, as well as involving the entire team with the patient-facing elements of the program. We also discuss transition needs and identify who will cover those needs during our weekly clinic huddle, and this is marked on our clinic tracker for the day. Our EPIC flowsheet use has allowed for transition data to be visible in the patient's medical record and thus accessible to all in the medical center. This has allowed us to improve our partnering, our goal setting, and progress reporting on each person, whether that visit be in person or virtual. Use of this has invited engaging conversations with patients and families regarding attainment of transition milestones, as well as goal setting for the future. It also serves as an excellent communication tool with the adult team regarding milestones or tasks that still need attention at the time of transfer. Transparency of this process throughout the medical center is essential for good communication, optimal patient care, and managing up this important work in our organization. 2 years later, we're finally getting to some of the larger scope work. One example is this decision tree regarding the timing of transfer. This is an area where we would like to have more consistency. Management of this process and having a tool to support it relates right back to our KDD, specifically timely ID of the start of the final pediatric year. Reaching consensus on a decision tree like this has helped us to ensure that our processes going forward are equitable and consistent. Now we are able to be more focused and planned, targeting specific areas for continued evolution or reevaluation. And I'm happy to share that our results are encouraging, and we are seeing success. We have realized that we still have work to do in certain areas, but overall the processes and tools that we have put into place are greatly benefiting our patients and setting them up for success, thus a better health outcome. I would like to call out some specific PDSA cycles, 4 of many, that have enhanced this outcome. The implementation of 2 readiness assessments in the final pediatric year, use of our integrated EMR flow sheet, the final year patient checklist for subgroup members, and lastly, our weekly clinic tracker. These 4 PDSA cycles have helped us to reach our goal. This depiction of our results holds us accountable on all the program components we are measured and the success of each. Some areas are very solid, especially the ones, in other areas, especially the ones with more moving pieces and parts, still need work. Current areas for reassessment and adaptation are consistent documentation, more targeted responsibilities during clinic, and revision of some of our goals. And just to call out to the low percentiles on the co-produced final year visits, as well as the readiness assessments, some of the members of our cohort were just too early in the project to have benefited from having those tools. And if we look at the people that are in the queue to transfer now, those goals are actually being met, and the percentages there look much better. So what about our smart aims? Our mean satisfaction score on a meet and greet survey was 23 out of 25 points, or 92%. Our patient readiness improved to 97%. And all young adults in the program had robust use of the EMR flow sheet, yet none of them met the 95% of initially designated milestones. Our next steps are to finish our post-transition survey. It's developed, needs revision, and a plan for implementation. We will partner with our adult team to get that done. We also will continue to build our transition program internally and externally, extending the fundamentals to other subspecialty clinics in our Children's Center. And we will continue to sustain the processes we have adopted and monitor for reliability, as well as adjusting our measures to make sure they are telling us what we need to know. It's no coincidence that this starts and ends with patients, those that have transferred and those that are getting ready to launch. If you leave here today with anything about this project, QI, or resource development, know this: the work is so rewarding and beneficial to our patients. They are very grateful and healthier when this process runs smoothly. We will keep using the patient voice to guide our work through all the different phases of life transition, which starts right from the very beginning and is an essential piece to doing this the best way. It's important we follow the same process for each patient every time to ensure equity in our transition processes and co-produced care at each phase of life. I'm thinking of all of our patients that are preparing to take the next steps in their transition process and feeling comfort that their experience doing this hard work will be a good one. The pride and empowerment our patients reveal to us when we partner with them fully to enhance independence is one of the best gifts we can receive as a care provider. Please come visit us at our poster 687 if you have any questions or concerns. Thank you.
Excellent talk. If anybody has any questions, please feel free to come up to the microphones. You can also, within the app itself, submit questions that we can call out on the iPad that we have up here. So,
thanks for sharing that great program. You had mentioned that you were getting a survey, I guess, after they had a chance to do these milestones. I guess I was thinking more about when the co-production at the level of feedback from your whole, like from the whole process of itself, and just can you talk a little bit more about the experience of where you were able to partner with patients and families, even like in like as evaluating the program, not necessarily at the individual encounter of getting those milestones together, but was there any kind of systematic collection of some of that, of setting those goals and being like, yeah, I'm really glad that we did all this whole process from start to finish?
I'm not sure I fully understand what you're asking, but
so if you
did they help us along the way?
Yeah, meaning in the design of you know, like of the entire, like setting up, you know, asking these questions, setting up the milestones, and did you get feedback that kind of iterated on the development of the program?
I would say on the setting up, and feel free to jump in if somebody else remembers anything different than me. We tried to do some surveys early on that just, we weren't ready yet. So we went ahead and set things up, as you can see, using a variety of different tools from different CF centers, got transition, like all the resources out there that were vetted before we actually started using the stuff. And then the meet and greet survey and the readiness assessments both have built-in Qualtrics surveys, so we can look at that data. But as far as the actual like build of the program, there was not an active patient presence in that.
I had one question. Specifically, which readiness assessments did you use? Do you know the name of them?
It's the EDA one now.
Okay.
So we took all the readiness assessments we could find, both inside CF and outside, and combine them all together to do what was going to work best for our program.
Perfect.
And just as a follow-up to that real quick, as we tested each of these tools, even though they're, I mean, we have CF parents looking at these things, but we've made changes along the way as they've been used, in answer to your question maybe a little bit better, and patients will, you know, if they say something like, well, I don't understand why you're asking me that, because we still haven't talked about that. So when we have revised the tools, it's because we've realized in real time that things were not either resonating with the patient or it wasn't something we were using consistently, so we would revise the tool.
Okay. I just have one final question. Often I find that at some step along the way in this process, I get surprised by the outcome. Were there any surprises along the way that you weren't expecting, things that you weren't expecting to be as hard as they were, or things that were nicely easier than you thought they were going to be to set up?
The nicely easier, at least in my view, is that I cannot believe how engaged patients and families are when you're doing this work with them. It really seems to bring people out of their shell quite a bit. And I was thinking about barriers when I was making the talk, and honestly, we have been so dedicated and focused that I don't see a lot of barriers. Our whole team is now involved, not just the subgroup, and we're actively working on it all the time. I mean, the obvious barriers of, you know, time and resources, both for the team and the patients, are always present, but it's such a priority for us that I haven't really felt that much.
Nice. Great.
Well, thank you. It looks like we don't have any other questions.
Okay, so our next speaker is Dr. Claudio Castaños. Dr. Castaños is the head of the Pediatric Pulmonology Department at the Pediatric Hospital Juan P. Garrahan in Buenos Aires, Argentina. He's the director of the CF Center. Dr. Castaños is a pediatric pulmonologist who's interested in CF and other child pulmonary diseases. He also spent some time at Pittsburgh, Pennsylvania at the Children's Hospital, learning about pediatric lung transplantation. And he's going to share a little about his center's improvement work.
Hello, good morning. My name is Claudio Castaños. Sorry for my English, it's my second language, so I try to do the best English today. I am going to present this work, that's the impact of effective cystic fibrosis center team training in low to middle income countries, our country.
Yeah, try
the enter button for that one.
Oh, now it skipped.
Well, I don't nothing to disclose. In Argentina, it's a low middle income country. CF centers in the public sector are giving appropriate resources to provide care. Example is a multidisciplinary team, laboratories, and med. However, outcomes and quality of life lag behind the developed countries. The Cystic Fibrosis Foundation has a long support and provide effective quiet training to CF team in the US. The Cystic Fibrosis Center, the Hospital Garrahan in Buenos Aires, is one of the largest CF centers in Argentina with 180 pediatrics patients. The centers include all core disciplines and adequate specialty consultants, but we have a core at this moment we have the core disciplines or the core physician, but we don't have a clinic because we attend in different times and different part of the hospital. So in 2019, Garrahan Hospital joined at the University of Alabama at Birmingham at the CF Training Network Latin America. That is a cystic fibrosis funding program that developed WAP specifically to train CF teams in low middle income countries. These programs include a bidirectional benchmark visit, monthly educational webinars, and quality improvements training. As part of this benchmark visit, our team first go to the WAP to the University of Alabama, and we saw a new form to work. So when we returned to Argentina, we begin to improve process, and now we have more than 20 new processes in our list. The first process that we improve is to attend all together in the same place of the hospital, so we can connect easily to all of us. The improvements and initial benchmarking was established a work plan, defined timeline to carry out the improvement, plan us according to the new work style, such as infection control, pre-consultation questionnaire, management appointment, add nurse, review data, document all this process, and define procedures and instructions. Also trained all the entire team for this new find to work or new work style. After the benchmark visit, we learned that we have to organize meeting, improve the clinic flow, knowledge, upcoming appointment, pre-visit planning and patient review, extra cleaning course space, and complete the CF center. So, so this is the fishbone of the center. You can see here that we don't have dietitian at this moment, and we have a poor clinic flow and also poor clinic place. So at the end of the fishbone center, we saw that we need a dietitian, that we could find one. Now we have a dietitian, we have more space, and we have a real clinic flow of the CF center. This is the clinic flow of the center. We saw where the dietitian will fit in to improve this, and where and we arranged the times for all this consultation. the dietitian could fit in this process. This is the 5 P's of the hospital. As part of this quality improvement program, we have invited to the Cystic Fibrosis Foundation to do the virtual improvement process course. So all the team could speak in the same form of quality improvement process. So the 5 P's of our center was the purpose was improve the quality of life and survival. So we have to optimize the time work to improve adherence and nutritional status of our patients, lung function, and educate the families. We have at this time we have 174 patients between birth to 18 years. We have all the core professionals. We don't have psychologists and social workers that we have on demand at this time. Now we also have the psychologists. Only we need a social worker, but we don't have at this moment. We have the appointment, the scheduled appointment at the court of the microbiology data, or the full of in 2 full days with 2 time blocks of 2 hours. In these 2 hours, all the physicians see the patients, and we saw between 8 to 10 patients a day. We have a preclinic meetings, and we have an educational process also. And the patterns of this was we have now weekly quality improvement meetings, weekly preclinics meeting, and all of this with we want to improve the body mass index and lung function of our population. As a part of the BIP course, we have to do an improvement process. That is the spiral of the microsystem improvement process that we do in this course. That we try to improve the lung function of the patient with the low lung function of the center. So we do an educational program to educate the families and the patients that in this way we think that we are going to improve also lung function of the patients. So now we are going to show you the results of this work. In the first years, in the outcome in the first years was the increase in the body mass index in all of our population, but we saw a marked improve in the children less than 2 years less than 2 years. That is so important because you know that the weight in the after the first year is correlated well with the lung function at 6 years. So when you have more the weight is better, also the lung function later is going to be better. But also we saw that all the patients improved the body mass index. After 3 years of this program that now continue, in 2022 we also saw that we can improve the lung function. The median of the FEV1 increased from 83 to 89, and the media from 80 to 84. Most of you can said me that this improves is because with the high effective modulator therapy, but these numbers is without these patients. We have 41 patients at this moment. We have 41 patients with the high effective modulator therapies. Now we have about 70 patients with high effective modulator therapy, but this number is without these patients. So we increased the number of the patients. Between 2018, 152, and now we have 180. The FEV1 also increased, the body mass index, zeta score increased, and the IV treatment is descends. I think that this diminish of the IV treatment was because the patients are better, so we don't need so much IV treatment. So in this picture, you can show I show you the pulmonary function in FEV1. In orange is the median, and in blue is the media of the patients. And in this part of the in the part of the bars, you can see in blue the patient with high effective modulator therapy. When we include the high effective modulator, the patient with high effective modulator therapy, and in orange without the patient, only the patient he don't have a high effective modulator therapy. So also without this kind of therapy, the FEV1 of the patient improves. So that is important because with this we show that we see that this improvement process is good for our patient. The both thing that we want to change in the beginning is the increase in body mass index and the lung function is going well. So we continue with these things. So in conclusion, an effective adaptable training program can be implemented quickly in low, middle and income countries, CF centers, and lead to significant improvement in process, clinical outcomes and quality of life of people with CF. So I think that that is an example of that could, when we have quality improvement process, all in our countries, all the CF centers could be improved the results. And this last is to thank to all my team in the Haragan Hospital, to thank Hector Gutierrez and the WAP team. And these photos in the front of our hospital, the two teams together in the last visit of the WAP team. Thank you very much.
Thank you, Dr. Castaño. That's a very impressive work that you've done. Are there any questions from anyone in the audience? If so, please come to the mic. Any questions? One.
I do have a question.
Thank you.
I am one of the people who had been the privilege to work with you. One challenge that we are seeing in the U.S. is the impact of the the modulators has led to our patients and probably us ourselves to kind of be not as strict with the basics, meaning the basic QI approach. Now Argentina has the privilege to have their local pharmaceutical industry being able to produce generic modulators to the benefit of the patients. Do you think, my question is, do you think now you can also drop the basics as we are facing the challenge here when your patients are not as well at the beginning of the treatment before, you know, the life expectancy for them is still much lower than in rich countries?
No, I don't think that we are less strict with the quality improvement or with the treatment. I think that the patient didn't do the same that before the high modulator therapies, but not our team. Our team is continue so strict than later, because we have patients with very well lung function, and we have others with very bad lung function. So, and also we have more patients. We couldn't use high effective modulator therapies like here in United States. So we continue the same kind of treatment as before for these kids. So I think that in most of the patients we continue so strict. as before the how effective modulator therapy.
I had one more question. Clearly, you've made a lot of changes, and your patients obviously have been a part of this and experienced this. Can you give us any feedback from your patients? Like, what is their response to some of the things that you've done?
Yeah, the patients are very happy because we went only one time to the hospital, and we see all the specialties. We do the laboratories, see if they need CT scan or other image they do in the same day. So they are very happy with this. And I think that they saw that the patients are better than before. I think the patient changed, but I think the more change are our team, the physicians and the nurse, and we empower all the team to work in the same form. So I think that is the best thing for us, this training.
Yeah. Okay. All right. Thank you very much.
Thank you.
Next, I would like to introduce Dr. Jordan Dunitz, co-director of the Minnesota Cystic Fibrosis Center since 2007. His presentation is a Cystic Fibrosis Learning Network Innovation Lab examining health-related quality of life.
Oh, there. Sorry.
Yeah, no, you're good.
So I'd like to thank the moderators for inviting me to speak, the CF Foundation for supporting the CF Learning Network, the group at Cincinnati Children's that has led this work, my co-authors, especially Brett Gamble, who has done the lion's share of the work, especially on the phase 2 that I'll talk about. All of the centers that participated in this work, and then especially all the folks at my center, my multidisciplinary team, their dedication gives me the bandwidth to undertake these kind of projects. So thanks to my team. So we're going to talk about the Cystic Fibrosis Learning Network Innovation Lab, examining health-related quality of life. Oops, I did that wrong.
Okay.
Sorry.
No, you're good. I don't know what happened. Let me. Before the arrows, I don't know why they're not working. You may be able to advance.
That work?
No. So then you may have to do it like this.
Sorry, a little technical challenge here.
Oh, see, it's just delayed, I guess. With
All right. I have no disclosures.
It may just be better to use that.
We'll do that. Oops. Oh, sorry. All right, so apologize for the delay there. So the Cystic Fibrosis Learning Network is a collaborative infrastructure for cooperation among CF centers. It is underwritten by the CF Foundation. It was developed to implement evidence-based, It was developed to implement evidence-based best practices and to test innovations intended to improve clinical and patient-reported outcomes. It's a system for data-driven collaborative learning. So it allows centers from across the country to collaborate in their quality improvement work. It has grown from, I think, started maybe at 16 centers and has grown to 36 or more centers. It has evolved over the past 6 or 7 years. And at the time we were doing this work, it represented about 6,300 patients among those centers. The iLab, and I'm going to be talking about an iLab that we worked with, iLab is an innovation lab which comprises a subgroup of the CF centers in the CF Learning Network, all interested in learning and innovating in a specific domain. And so the idea is that all of the centers involved in the iLab cooperate together on a similar project with similar goals in mind. But this allows us to say, do these innovations work at centers of different sizes, rural, urban, with different care models. And so it allows us to sort of look to see whether the innovations we're looking at can actually be spread among, across the network, rather than testing at a single program with sort of single characteristics. We're testing over across many programs, hoping that this will then be applicable across the network. I'll get this, I promise. So why is assessing and intervening on health-related quality of life important? It's valuable to people with CF and their families. So people living with CF and their families have been clear that their broad well-being and quality of life are at least as important to them as specifics of their CF care and their treatment. They don't want to just talk about PFTs and BMIs and lab values, but really about what's their quality of life, what is their day-to-day life with CF. And it's equally valuable to our teams because we want to respond to that need. So care teams try to meet families' broad needs, but usually don't have a systematic, routine way of understanding and responding to those needs. So we have our typical clinic visits where we say, how are you feeling? And, how are the PFTs and the exam and all of that. But we don't really necessarily get the sense of what their broader needs are. And so the idea is kind of a systematic approach to learning these needs. So the timeline. The first email, I was on vacation visiting my parents in Maine, July 2019. We're trying to figure out how could we start to meet and plan this iLab. It took a lot of sort of preliminary planning. So we had our first design meeting in December of 2019, where we had content experts get together and figure out how we're going to do this. We launched the iLab itself in March of 2020. So all the centers are participating, started meeting together to kind of figure out exactly how we wanted to move forward with the iLab. Phase one, the actual activity started in January of 2021, went for a year to January 2022. Phase two was February of 2022 to March of 2023. And then phase 2B, we're actually still working on that. But as you might remember, there were a couple of events that occurred during this period. So right before the design meeting, ETI came out, and clearly that's had an impact on people's quality of life. And so, but by the time of the meeting, while it was out, by the time of the design meeting, while the drug was out and we'd probably written a handful of prescriptions, we probably didn't have one return visit to really have a sense of what that impact was. So we were kind of designing this to a great extent pre-ETI, even though it had been approved, we really probably hadn't seen a patient back to get a clear sense of the benefit. And then COVID. I mean, COVID had a dramatic impact in all aspects of all our quality of lives. And, maybe more so, certainly more so for the CF patients, but all aspects of quality of life were impacted by COVID. So it was some challenging times. So phase one. So using the model for improvement, in order to improve health-related quality of life, we had to be able to measure it. So in order to sort of move forward using the standard QI methodology, we wanted to be able to measure QI. And we wanted to measure it every visit, sort of once a year. We thought was too far apart. We wanted to be measuring quality of life every visit. We wanted something that was easy to complete, or if patients were going to do it every visit, it needed to be easy to complete. It also needed to be easier for the providers to score, so they could sort of take a look at it and address it during that visit, as opposed to sort of over time. So we selected the Promise 10. It's a validated, it's pediatric and adult versions. It's easy to complete. It takes under 2.5 minutes, I think, to complete. And it's easy to score. You can kind of just glance at it as a provider, a member of the care team, and get a very clear idea of where the patient stands. It does not replace the GAD-7, the PHQ-9. And this has been a concern that folks have had. We're not for a minute suggesting that it would replace the GAD-7 or PHQ-9, but it does allow, often those are given annually, and this we're doing every visit. You might wonder why we didn't use the CFQR, the sort of more CF-specific quality of life survey, but it's so extensive that it isn't something patients would fill out every visit, and it's too long to actually look at during a visit. So, excuse me, phase 1, 12 centers or programs are involved, 7 adult, 3 pediatric, 2 combined. And the programs varied anywhere from 63 to 450 patients. So the idea of this iLab was, can we do this in any size center that has various technical skills and, various other characteristics. And so each program actually determined how they're going to administer the Promise 10. Was it going to be electronic? Was it going to be paper again, allowing us potentially to spread this across the care network? And these are the centers that were involved. So our aim, the global aim, is to increase the number of individuals with improved responses for the Promise global quality of life. Specific aims, phase 1 was focusing on improving measures. We had to see, could we even measure this? Because there was no sort of history of measuring this on a regular basis. The 2 specific aims were to increase collection of health-related quality of life from a baseline. It hasn't been done, so we didn't really have a baseline, to 80% by December 31st. And then once we started looking at it, we wanted to increase the review of the health-related quality of life baseline 89 to 93. We thought if the provider or someone on the team doesn't review it, the patients are going to stop filling it out. So we thought that it was really important to monitor whether or not it was being reviewed. So here is our first control chart looking at actually how many patients filled it out. We started around 56 when we first started the iLab, and we got up to 74. So we didn't quite hit our goal, but in terms of patients filling out a survey every visit, we felt that this was, we were fairly happy with this. The x-axis, you'll see we used, rather than dates, we used groups of 50 patients because different weeks there were different numbers of patients being seen, and so it was causing a lot of variation that probably wasn't reflecting reality. We did get up to 93% of reviews, so the majority of the time that the patients filled it out, it was reviewed. So, but we're really about trying to improve quality of life. I mean, measuring it was the first step, and to some degree uninteresting, other than the fact that we needed to know that we could measure it in order to impact on it. As it turns out, with the advent of ETI, physical health was actually really good. Most folks are scoring very high, and we felt this wasn't where we really need to give attention. It was really mental health, and what we were looking at was the 2 mental health questions. In general, how would you rate your mental health, including your mood and your ability to think? And how often have you been bothered by emotional problems such as feelings of anxiousness, depression, or irritability? And it's scored from 1 to 5, and basically 1 and 2 were the suggesting that there were some mental health issues. So phase 2, 3 programs stayed for phase 2. The specific aim here was to first establish a baseline of percent of completed questionnaires who were responding either 1 or 2. So what percent of our patients at any clinic visit were indicating they were having problems with mental health? And what we found was it was somewhere around 14%. About 14% of patients at any given clinic visit were giving us either a 1 or 2 for one of those mental health questions. So then phase 2B was really the meat. What we were really about for the past few years of trying to get this done is, could we reduce the percent of completed questionnaires with a response to mental health questions 1 or 2 from 13 or 14 down to 11? We thought it's always been difficult to impact mental health, so we were not anticipating a huge change, but if we could move the bar at all, we would be happy. So we had 2 interventions: a co-produced mental health plan with the social worker. So anyone who scored a 1 or 2 would meet with the social worker, and they would have would co-produce a plan to how they would approach the issues with their mental health. And then schedule a specific follow-up to check in on the progress. So it isn't just, well, we'll see you next visit, but we're going to, between the social worker and the patient, they agreed, when are we going to check back in? A call in a couple of weeks, a call in a month, to see, were you able to implement this plan and was it effective? And we're developing we've developed a tool to track the barriers to these interventions. So we're, people who weren't able to initiate these interventions, we're getting a sense why, which will be a later phase of the study. There was a bump in the road. So there were 3 groups, Portland, us, and Stony Brook. We lost one of our social workers in the spring, and Stony Brook also, their social worker went on a leave. So it kind of threw a little wrench in the works. But I do want to show, and this is just from Dornbecker, and I really want to thank Zoe Orcutt, who really is to thank for all this. But what you see is that the percent of patients that were at a 1 or a 2 went from about 14%, and after we implemented the intervention and maintained it for a period of time, and it isn't like, you give antibiotics and a week later they're better. These interventions take time, but we actually went from, we went from about 14%, actually not to 11, but down to about 6 or 7%. And so it appears, at least at one center, over time, we were able to actually have this impact on mental health and the folks that participated. So the conclusions are that health-related quality of life can be measured consistently in clinic. Approximately 14% of people with CF report mental health challenges. And we have a patient partner on the team, and they said, if you had 14% having exacerbations, this would be, a call to action. And so, this rate of mental health issues, and not that we're not all familiar with anxiety and depression in our patients, but this level at any given visit is really a call to action. Co-production and scheduled follow-up may help to reduce the number of people with CF reporting mental health challenges, and clearly the social worker is essential for this process. So thank you to all the social workers here, and a special thanks to Zoe, who gave me some results to talk about.
Thank you so much for sharing your experience. Quality of life is really hard to impact, and mental health is definitely hard to impact. So that's impressive that there's been a shift in the baseline. Does anybody have any questions? If you do, come up to the microphone, please.
Just a couple comments. Mike Powers from Portland. Really appreciated Jordan's partnership with Zoe. It's been shows how interdependent leadership in our network works. The PROMISE survey is super easy to do for the patients and for the teams. Either they do it in Epic ahead of time, or they do it on a day of visit form, and it's become standard in our clinic. It's on our one, we've turned it into one sheeter, and they get it plus other questions, and they all fill it out. They expect to fill it out. And then the other thing I've learned from this and other QI things was the tracking tool makes a big difference for spread. I shared a tracking tool and timely data entry with a team I was coaching at UC Davis, and they improved their timely data entry remarkably because they had the Excel tracking sheet to implement the action. So really spreading these tracking tools is really important.
Thank you.
I have one question. You mentioned that there were several different interventions, and I know for our center that intervening in mental health issues is often the biggest barrier. There's either no services available or the patient doesn't follow through. What types of things were you using for interventions that maybe worked best? Or
we don't know yet what worked best. That's kind of the goal behind that tracking sheet. Certainly there were referrals to mental health providers, either psychology or psychiatry, counseling by social workers. Some of them were things like, people felt lonely, sort of figuring out ways to address loneliness. So, discussion, reach out to friends or whatever it was. I don't think we know yet what worked best, but it was very individualized, which I think was part of that sort of co-produced plan of, what is dropping you a 1 or 2, and so, very specifically addressing that.
Hi, this is Brett Gamble, and I worked with Jordan on this. And I was just going to add to what Jordan said. I think that's what we were looking for, is what works best, and we still are learning. We're able to put charts together to figure that out. But the one thing we saw worked best was follow-up, because it's just one of those things where patients communicated back that they felt like that if they did something, someone was going to check in. So that accountability piece, which is why the tracker is so helpful, is it helps the team to be able to do that. So it didn't really matter. I mean, we don't fully know, but it doesn't seem like it's so much exactly what you're doing, but the fact that someone's following up and there's accountability does seem to be helpful. And meeting with the provider and talking about it then identifies what the unique strategy is. So we'd love to have like one answer, but I think it's probably very individualized.
Yeah. Okay.
Thanks, Brett.
Thank you.
Thank you.
Any other questions? No. Thank you.
Thank you. Okay, our next speaker is Brittany Haas. Brittany is a family nurse practitioner at Nationwide Children's Hospital. She started as an RN working with CF patients, and then after earning her degree, moved to the adult CF inpatient service in 2019. Now she works with adult and infant cystic fibrosis outpatient clinics, and she's very passionate about her work, and she's going to tell us more about their team's work on newborn screening and improving the timeliness of sweat chloride testing.
All right, good morning, everyone. My name is Brittany Haas. I am a nurse practitioner from Nationwide Children's Hospital in Columbus, Ohio. And today I'll be talking about the creation of an abnormal newborn screen response team and how it improves timeliness of sweat chloride testing. So none of the authors of this presentation have any relationships to disclose, and this project was funded by a grant from the Cystic Fibrosis Foundation. So I'd like to start today by talking a little bit about putting in context why this work is so important. So really the primary goal with this project is to make early diagnosis for any of our infants with abnormal newborn screening for CF. And we know this is really important in the era of highly effective modulator therapy. And as these medications continue to get approved down to younger ages, early diagnosis becomes even more important, especially now that ivacaftor is approved down to 1 month of age. We have to make that diagnosis before 1 month of age in order to start that medication. And newborn screening has been instrumental in identifying these infants early, but we know that missed and delayed diagnoses can still occur. And as a screening test, it will never be perfect, but our goal is to find as many infants as possible as early as we can. So the Clinical and Laboratory Standards Institute recommends that all infants with abnormal newborn screening for CF have sweat chloride testing within the first 30 days of life. And when we look at national data based on US registry data, we see that only 52% of infants are meeting that recommended sweat chloride testing within the first 30 days of life. So there's lots of room for improvement. So we're from Columbus, Ohio, and when you look at our screening region, you can see here that we are screening region 4, so we are the largest screening region in Ohio. And when we look at our local data, we see similar trends to the national data. We have lots of room for improvement in getting that sweat chloride testing and diagnosis early. So this is data from 2021, but when we look at our data, of the 117 abnormal newborn screenings in our region, only 18% of all infants had abnormal newborn screening. With an abnormal newborn screen, had sweat chloride testing within 30 days of life. Of our 10 infants diagnosed with CF in 2021, only 50% of those were seen by our CF clinical care team within the first 21 days of life. And about 10 infants actually never completed sweat chloride testing, so that's about 8.5%. So we had a lot of room for improvement based on that data. So we started our QI project in August of 2022. And again, we received a grant from the CF Foundation that supported this work. And again, our primary goal with this project is to find these babies earlier and improve the accuracy and efficiency of the diagnostic testing process for infants with an abnormal newborn screening in our region in Ohio. And we really wanted to make sure that we were addressing socioeconomic barriers and racial and ethnic disparities, because we know that inequities exist in the system and contribute to a lot of delayed and missed diagnoses. So looking at our key driver diagram, both of our project's aims are focused on decreasing the time that it takes to identify, notify, and engage with infants who have had abnormal newborn screening results. So our primary aim was to increase the percentage of infants with CF who are seen within 21 days of life by our CF clinical care team from 50 to 80% by January 1st of 2024 and maintained for 5 years. And our secondary aim was to increase the percentage of infants with abnormal newborn screening who complete sweat chloride testing within 30 days of life from 18 to 50% by January 2024 and maintained for 5 years. So today I'm really going to focus on our intervention of creating an abnormal newborn screening team because we really saw the most success with this. And it really helped optimize our scheduling process, improve family notification and education, and increase successful completion of visits. So when we looked at our prior process, we had a lot of challenges. We really were relying on the primary care doctors to disclose the newborn screening results to family, which often led to a lot of confusion, and families were getting a lot of incorrect or incomplete information from primary care. Once the PCP had disclosed those results to the family, a member of our administrative staff would reach out to the family to schedule a sweat chloride test. And we found that families were often very confused and had a lot of questions that our administrative staff were unable to answer. So this led to, again, a lot of families misunderstanding the urgency of follow-up testing. And we really saw this kind of go both ways of families were not concerned enough and would miss appointments, or it created unnecessary worry and angst more so than was necessary. So how can we fix this? Our solution was to create this abnormal newborn screening team. And this is comprised of a multidisciplinary team. So we have a CF physician, a nurse practitioner, a nurse, and a genetic counselor. And our goals with this team really are to take ownership of communicating abnormal newborn screening results to families, because as the experts in CF, we are the best qualified to really review these results with the family. And we really want to make sure we are providing consistent education to families in an easy to understand manner, so families really understood why they needed follow-up testing. Another goal was really to streamline the scheduling process and make it more efficient and hopefully minimize the number of phone calls for our families. And all of the members of our team received training in health literacy and teach back, really to make sure that our communication was clear and easy for our families to understand. So looking at our process map, each of our team members is responsible for reviewing newborn screenings on a specific day of the week. So any of the newborn screens that come in, the team member will review and take ownership of that. And then the first step is to reach out to the PCP office. So we still allow the PCP to review the results with the family first, since they already have an established relationship. But we're initiating that communication with the PCP office earlier, and letting them know our plan to reach out to the family to call and schedule, review results and schedule that with the family. And we've really seen positive impact. The PCP offices are often appreciative when we do reach out to them. So for our infants that only have one mutation on newborn screening, we call the family and review those abnormal newborn screening results, and then talk about the plan to get sweat chloride testing. And we actually schedule that visit while we're on the phone with the family. Then we'll route the chart to our admin, who will then schedule a results visit with our genetic counselor in Epic. And then once they have sweat chloride testing, if that testing comes back normal, then they have a results visit either in person or by telehealth with our genetic counselor. If the sweat chloride testing comes back abnormal, then we add them onto our CF clinic, and it'll be a full visit with one of our providers. For our infants with 2 mutations that we find on newborn screening, we actually do disclose those results over the phone and the diagnosis over the phone, and we schedule a visit with our clinical team typically within 2 days of the phone call. We'll then route that chart to our admin to get that scheduled in Epic. And another big job of our admin is sending out patient education documents, which we spend a lot of time revamping. And we really want to make sure our families have a handout to reference after our call with them, because we've learned these calls can be really stressful, and it's hard for families to retain that information. So we're making sure we're sending resources for them to utilize after the call as well. So then once that visit gets scheduled, that's when our CF clinical care begins. And with the, we did create a patient education document specifically for our patients with 2 mutations identified, and really focused on the information that they need to know between that initial phone call and that first visit. So that can be a really stressful time for families. So when we look at our results, we saw pretty quickly what a powerful impact this team made. So within 1 month, 100% of sweat chloride testing was completed within the first 30 days of life and has continued to be sustained above 70%. And then when we look at our infants with CF, so we had 9 infants that were diagnosed with CF, and 100% of them were seen within the first 21 days of life in our CF clinic. And anecdotally, we're seeing that families are coming into these visits with improved understanding of the results and possible diagnosis. So this is a graph of the percentage of infants with abnormal newborn screening for CF who complete diagnostic sweat chloride testing within 30 days. So if you remember, our goal was to go above 50%, from 18 to 50%. And you can see our QI grant was awarded in August, and we officially rolled out our team in October. You can see pretty quickly how much our numbers improved with the rollout of our team. And then when we look at the median days from birth to sweat test completed, again, we're seeing a huge improvement there. We improved from our baseline of a median of 32 days to a median of 21 days. And that really is important, again, as these modulators get approved, even down to 1 month of age. If we're getting that sweat test by 21 days of age, we'll be able to make that goal of starting the medication at 1 month of age. So when we look at our new process, we found a lot of strengths. As the CF team taking ownership of communicating the results with the family, we're able to control that messaging and ensure results are clearly explained and communicated with the family. We're also reaching families earlier, so the earlier they're aware of the results. Again, our median days from birth until we actually talk to the family and notify results is around 10 days. So that gives us a lot of time to make sure that sweat chloride testing gets done by 30 days and address any barriers or repeat testing in the case of QNS results and still meet our goal within 30 days. And utilizing training in health literacy and teachback has helped us make sure that we're clearly communicating results and that families have a better understanding of the newborn screening results. And we've really found that when families have better understanding, that leads to more timely and successful sweat chloride completion. There are many challenges that make it difficult to complete sweat chloride testing within 30 days. Some of these are unavoidable, but we continue to work on finding solutions. And really the best solutions that we've found have been really just standardizing our processes, improving communications with both families as well as other providers, and that includes both PCPs as well as other CF centers, and offering resources to families to help address socioeconomic barriers. And we're happy to see the positive impact on our data, but it's equally important to ensure the process is as smooth as possible for our families. So another thing we've done is created an electronic survey to get feedback from our families. And we're really looking at their satisfaction, their understanding of results and the diagnosis, and the helpfulness of each of our interventions. And what we've really learned from this is that every family has different preferences for how much information is provided during that initial phone call. And we're really utilizing their feedback to help tailor our approach to our families in our phone counseling. So what has been helpful as we've implemented this team? One of the things we've learned is as we're contacting these families earlier, we're trying to be mindful of not scheduling sweat chloride testing too early and increase the risk of QNS results. So one of the things we've looked at is considering gestational age and birth weight when we're figuring out our goal timing of sweat chloride testing. We also know that health literacy is reduced during times of stress, and the addition of a new baby the newborn period is stressful enough, and then we add in these abnormal results and it's really stressful for families. So we really want to make sure that both our oral and written communication is in plain language and easy for our families to understand. So we're spending a lot of time focusing on that as well. And then we've created dot freezes to help with the efficiency of documentation. So then we're really able to invest the time that we need to have these conversations with families. So some key takeaways. A dedicated, compassionate team makes all the difference. And we've really gotten positive feedback from our families, and they appreciate us spending the time explaining the results and allowing them to ask questions. And clear communication, it seems really simple, but it makes a really big impact. And we've seen great success with the implementation of this team. And with that, I would like to say a huge thank you to our team. It truly is a group effort, and I think that's one of the awesome parts about CF Cares, our multidisciplinary team, and that's true with the diagnostic testing process as well. So a huge thank you to our team, Kimberly Paisley, Matt Pastori, Amy Wood, Charles Hardy, and Dr. Caitlin Kravchenia. It really is a group effort.
Okay, that was a great presentation and great work. And while others are coming up to the mic, I have one question, and maybe or maybe not you looked at this, but for us, QNS is often a problem with smaller babies, and it takes a while for them to get big enough. Did you have any, obviously, maybe challenges like that, and what was helpful in that instance?
So we've definitely been following QNS rates as a balancing measure. So I think we have teased through the data, and there's a lot of different things that we're looking at. But I think one of the things when we looked at our data, really we were seeing that premature babies, that was kind of the highest risk of QNS. But then also like the gestational age at birth and birth weight really made a big impact as well. So as part of our kind of standardized scripting, we have a goal sweat chloride testing timing. So depending on, again, gestational age and birth weight, our goal is either between 2 to 3 weeks or 3 to 4 weeks. So we really do tailor that timing based on those factors.
Good. Thanks for that great presentation. Do you have an opportunity with this information to go back and look to make sure that the intervention was delivered equitably?
Yeah, and that's a great question. And again, a big goal with this project really is to make sure things are equitable. So that is part of what we look at. We do look at demographic data. We're also looking, as part of this project, we're partnering with Ohio Department of Health, and we're really looking at our panel as part of the newborn screening results and how, which panel makes the most sense. Because we have seen some missed cases at our center within the past year. So we're trying to make sure that our process is as equitable as possible, because we have seen some inequities in terms of racial and ethnic disparities. So yes, we're definitely looking at it, and it's ongoing.
Great presentation and great project. In St. Louis, I'm from Cardinal Glennon, and we have 2 pediatric centers that are both struggling with the newborn screen program. And it's twofold, as you elicited to. 1, just creating the program, but 2, the QNS sweat test that you've already asked about. Are you willing to share that spreadsheet with regard to gestational age and weight? I haven't seen anything like that in the literature, and I'm wondering if that will help our QNS rate. Currently, for the less than 3-month babies, we have a very high QNS rate, and greater than 3 months, it's near 100%, between 95 and 100%. The frustration we encounter is our lab feeling frustrated because they get the small babies and misinformation is given to the parents. The babies are too small, return in 3 months. And so I don't know if you've also had those issues with your lab, and how do we navigate pulling our lab in to be part of our team, which we've tried, but I feel like sometimes there's a division.
Yeah.
Thank you.
Yeah, that's a really great question. And we've definitely encountered challenges with the lab. It is hard since it's a little bit outside of our department, and we have set up ongoing meetings to improve that communication with lab staff. One of the things we had also tried to see if it made a difference in QNS rates is we looked at whether arms versus legs were better in terms of QNS rates. So we primarily were doing them on the arms, and I think that's actually what the CLSI recommends. But we were curious in these really small babies if their legs were more successful at or less risk of QNS. And we actually, when we look at our data, the legs did not perform as well as the arms. So we're going back to the arms. But yes, we have kind of informally looked at a lot of that data with our lab, but I think we'll continue to look at that. And if we find data that's helpful to share, I'm happy to share that with people.
Hi there. Great presentation and great work. I do a lot of newborn screening and have done a lot of the quality improvement at our center, and it's been a struggle. The CLSI guideline doesn't specifically say, it's the CFF guideline, that they want babies in treatment by 30 days of age. And so we use an IRT DNA, and like we kind of prioritize who gets sweat first by the level of their IRT. We've also done things for equity with rolling cutoffs and things like that. The other thing we did is we actually developed, we have a great relationship with our state newborn screening lab. And so we developed together the mailer that goes to the family, has a QR code that has a video, both in English and Spanish, that gives them specific information of why this is important. There's a couple with their newborn baby getting sweated, and they talk about why it's important, and it's just been a lovely additive for us.
That's awesome. Yeah, we've looked at a lot of different things, like even improving our website. And one of the things we worked with the Ohio Department of Health is changing the language on the newborn screening, because there's a lot of confusion there as well. So we've been working on that. But I love the idea of a QR code to a video. That's an awesome idea.
Okay.
And I think that could target both education for families and for primary care providers too.
Great.
So thank you.
Thank you so much.
For our last presentation, I would like to introduce Jamie Vida, the CF Program Coordinator at Seattle Children's Hospital Cystic Fibrosis Center. She will talk about improving accuracy of self-identification of race and ethnicity among people with CF at a pediatric care center.
This is really delayed, so I wouldn't be back. So I think for Brittany, she was using that, or you can just click.
Great. Good morning, and thanks for including me in this presentation. As mentioned, I'll be talking about improving accuracy of self-identification of race and ethnicity among people with cystic fibrosis at a pediatric care center. No relationships to disclose related to this presentation. Our story at Seattle Children's began with the Community of Colors report, which discussed differences in CF care among people of color related to delayed diagnosis, feeling a lack of trust, and a lack of representation, and having limited access to education support. Our quality improvement team is supported within the Cystic Fibrosis Learning Network, a collaborative learning health system to conduct quality improvement among skilled team members, including 4 parent partners. 2 of our parent partners are from outside of the United States, and each had shared unique experiences about their care, including one not being offered prenatal testing because she identified as Hispanic. Our QI team reviewed our CF center data and noted there were striking differences between Port CF and our electronic medical record. This raised many questions which steered us to our project work. Steered us to our equity project. We don't know what we don't measure. This is what quality improvement is all about to us, our team. As a team, we have the goal to practice best quality of equitable care, CF care, that reduces or prevents health disparities and meets each patient's unique needs to achieve optimal outcomes. This sounds very lofty, and as we looked at our data, these 2 questions emerged. First, how do we practice equitable care without knowing if race, ethnicity, and language is accurate? And then secondly, how do we talk with families about the importance of race and ethnicity and language information and how we use it? Our team found these 2 questions at the beginning that guide us in our scope of our project. Eventually, we landed on our SMART aim of 80% of people with CF will have the opportunity to self-identify and verify race, ethnicity, and language information in the EPIC electronic medical record from October 2022 to May 2023. Our What We Did slide. This slide provides an overview of our project flow. It was created by co-production of our parent partners who presented this work at a CLFN conference this past year. As you can see, focusing on the rainbow boxes, we ran our EPIC EMR report and compared this data to what was in PortCF and found differences. We found differences in choices as well, so what you can choose. From there, we consulted our institution team with our questions, and this steered us to crafting our MyChart communications, and then we analyzed who responded, documented changes, and drew our conclusions. Next, I will show you some tools used in our project work. Quality Improvement Toolkit. I'll go into detail about the quality improvement tools we used in our project. Co-production was an impact in each tool and fostered building trust. We started this project charter with a tool designed to establish how to navigate and scope the project. And this helped us figure out how to begin the project with our many questions. We then created a key driver diagram leading us into a process map, and then finally our PDSA cycles. Again, our entire project was carried out with significant co-production with our parent partners in every tool. This is our project charter. It helped us navigate our whys and define the scope of our project. It provided structure to this project, and it was a great starting place for us. We spent a lot of time on this. So here's our key driver diagram. This organized our ideas, and we discovered causes that were contributing to what we were trying to improve upon. It led us to our aim and identified our interventions we need to do. So a definition of a key driver diagram is a tool intended to help organize your ideas and discover various causes that contribute to the issue you're trying to improve. The key drivers break down the aim of your project into primary and secondary drivers and help you determine what changes to make. Building a key driver diagram is a collaborative team process for all voices to be heard. Another way to see the project is understanding the current process. The purpose of a process map helped us identify barriers. We could identify what was happening in the current process in real time from our PFPs, or parent partners. So co-production provided instant feedback for us. Process mapping is the first and most important step in digesting complex workflow information, understanding the status quo, and identifying opportunities for improvement. By providing the visual representation of data, process maps highlight waste and vulnerable process steps, and mapping our current process was essential to understanding the patient experience and identifying race and ethnicity and where there might be opportunity for improvement. Our parent partners showed us what was happening in real time with their experiences at checking in to their appointments on their mobile app. They also noticed changes over time in our tests that the check-in process changed. So we were getting, again, more instant feedback. PDSA ramp summary. There's a lot on this slide to see, so let's focus on the blue boxed column to understand what a PDSA can do. It intends not to read this entire slide, it's a lot, but to see the ramp of test cycles over time. Ramps are a great visual to show your tests over time and connect to your smart aim, and you can show it with other team members as well. PDSA. Plan, do, study, act. The 4 stages used to improve your process and to create change. Plan, what do you want to do, and then create it. Do, launch your test. Did anything change from your previous test? And studying it, what did you discover? Action, act. Did it work? Does it need to be modified? Did it not work? Can you adopt it into its current state, and can you sustain it? So the ramp did take some time. As you can see, the cycles went from August to November, and some cycles can be faster than others. Building trust and communication. This is our key slide. Again, co-production was foundational and essential in creating this communication. This is the communication we landed upon, explaining our why. How do we build trust with our patients and families? We value equity and want you to know how we will use this information responsibly. Our multiple PDSA cycles were carried out because of co-production, resulting in communicating our why and how, and building trust through language was key for us. Our parent partners were essential in our testing. They showed us what was happening while they were checking into their child's appointment. And again, as I mentioned, they noticed that the process changed. We went through this process. The message was sent in my chart. We did this by bulk messaging, which was new for us. And we did this at 2 different time intervals. We discovered that not all patients had my chart available. So to ensure inclusivity and equity, we identified the need to extend the reach and included this communication in our CF newsletter, which we send both electronically and by snail mail. Our findings. This figure is how the flow of how our patients responded to us. And then we found out of our 181 patients, my chart was an efficient way to send communications, but only 31 out of 105 who read the message had no changes, with 8 updating the electronic medical record, and 6 of those expanded expanded to multiple races. What we still do not know is who didn't respond to read the messages. And there's those who still do not have my chart, so we're still learning how to reach all patients. Even from something relatively small, one can create a process map to show someone the steps. This was the outcome to our PDSA cycles. This tool is a great way to share the work with other team members, and it can also contribute to sustaining the work. It's a good idea to revisit tools, as this can be a roadmap, and this became our roadmap for the entire project. This is what we do after doing all of our work. Lessons learned. What we learned was we focused on trust and learned to be uncomfortable in discussions of race and ethnicity to grow and change. Family partners were essential to design and test within this project, helping us build camaraderie through difficult conversations. We do not know why families did not communicate back. Families that changed their race, ethnicity, and language data identified multiple races, reinforcing the importance to provide the opportunities to ask. My chart alone is an insufficient way to communicate, so we need alternative communication approaches. And our data team has adopted a standard process to update the cystic fibrosis patient registry with EPIC identified race, ethnicity, and language data, and we review this process regularly. And I'd just like to thank our Seattle QI team, our parent partners, Sin, Claire, Megan, and Lisa, thank you. Our Seattle QI, our Seattle Children's data team was, I'm really fortunate to be a data team of 3, so we get to share the wealth of inputting all that data. Thank you, Gracia and May. Thank you to the CF registry team and its resources. Thank you to the CFLN, and also if you want to learn more, you can see our poster number 691. Thank you.
Thank you so much for sharing this project with us. This is very important work, and I think a lot of us can learn from what y'all have done and what y'all have learned. If anybody has questions, you know the drill by now. Come up to the microphone or enter them into the chat. There are none in the chat. So while I have the microphone and I have the power, I'm going to ask a question. I have a question about, have you had any instances where either the parents disagree about what to put or self-identify as, or where a parent and a child have a disagreement of what to put, and what have you done about that?
Well, I don't think we've asked that in particular to the patients and families, but some of our data, we did have a family with siblings that had different identifications. So that was like an aha. It's like, but why was that? The complexities of families. So could it be true? Could it not be true? Mm-hmm. So again, that was a need for this ask to, and we ask 2 times a year for our patients and families. So yeah, that's, and interestingly enough, through some of the communications back through my chart, I'm getting so much better. Epic's still kind of new to our center. We converted right during the pandemic. But we did have some of our 18-year-olds and older answering back in our a lot of like why, and it's kind of some teen things, and it was like, well, this is because of this, or I don't want to, but at least they were communicating, so they read the message. Maybe they didn't want to answer, but.
Jamie, how did
Yeah.
your team use the new information? Do you use it to identify people for research studies? Do you identify
Exactly.
it for a specific QI project? How have you implemented it locally, having this new knowledge? I was hoping team members look at this new information, use it in your clinic visit to have more empathy, but I don't know how much uptake I got on that.
Yeah, I think that's still where we want to go with it. Definitely research is it, but we also want to make sure that it's reliable, that you can count on what you see is as accurate as possible, and that it is their true voice that they got to identify. And right, you're asking about the teens, or and some teens are changing things, and we're trying to see what Epic can do. Our Epic, I think, is expanding the options and the choices for who you are, who you want to identify as. I've had lots of continued questions with the registry that they haven't been changing. So it's comparing apples and oranges. You can have this great work in Epic, but how does that translate into Port CF? And we still have a lot clicking on the unknown box because it doesn't fit. So that's definitely some work still to be done. But I think research and just could go into quality of life of people. It's like, opportunities and making sure that we have things in different languages. That's another big a push that we're trying to do, not just Spanish, but perhaps Ukrainian or other languages, either written or and making sure consents are that way as well. So
That's great. Do you think building trust, maybe just by asking the questions, building trust might improve care as well?
yeah, I think so. I think that, it's going to be I'm not a clinician, so I think I can't really speak to it exactly, but I think that, it's with empathy and compassion that, it's like we're asking this, so that we're seeing you as your whole person and your voice is heard and we hear you. So we're working on a lot of bidirectional communication also with our patients and families. It's like you responded to us in a day, a questionnaire. It's like you need to know we read it and we're getting back to you. So if something's not right or the language is, you can't view it in Epic because of it's not the right language.
Thank you. It's great work.
Thanks.
Okay.
Done.
Thank you so much.